Good afternoon, everyone. I'd like to welcome you to a webinar presented by Healthcare Can in collaboration with one of Healthcare Can's members, the Sinai Health System University Health Network Antimicrobial Stewardship Program. My name is Charles Thompson. I'm a Policy and Research Analyst at Healthcare Can, and I will be moderating today's webinar. The topic of the webinar is recent national developments in antimicrobial stewardship with a particular focus on surveillance of antimicrobial use in Canada. We're very pleased that so many of you have made yourselves available to join us today. That's the welcome and introduction slide. So before we get started, I want to point out that if you experience any technical issues during the webinar, please contact the number provided to you via email before we got started. Just wanted to walk through some features of the technology. This webinar is being recorded. However, do not find it at all odd that you are not able to speak, as we have muted the line for non-presenters in the interest of efficiency. We will be getting your feedback and answering questions at the end of the presentation. If you have a question or feedback, please enter it into the Q&A pod on the right side of the screen labeled chat. At any time during the presentation, questions that are typed will be visible to everyone. Please keep those questions in mind during the webinar. There will be about 15 minutes to answer any questions you may have for any of our presenters at the end of the session. Additional questions can also be sent after the webinar, and we will all ensure that you receive an answer as well as a recording of today's webinar. So we will be starting off today with Healthcare Canada President and CEO Bill Fohl. In collaboration with the National Collaborating Centre on Infectious Disease and with the support of the Public Health Agency of Canada, we held an action roundtable on antimicrobial stewardship in June of 2016. That roundtable resulted in a stakeholder-driven national action plan on antimicrobial stewardship. Bill will start us off by giving a brief bird's-eye view of the process that produced the action plan, as well as the steps that are being taken to implement that action plan. Following Bill's presentation, we will hear from Dr. Andrew Morris and Yoshiko Nakamachi, who will together lead the SHS-UHN Antimicrobial Stewardship Program in Toronto. Andrew and Yoshiko will be providing the Canadian context for antimicrobial use surveillance, which we all know is a critical piece of the overall stewardship picture. Andrew and Yoshiko will speak to how we measure antimicrobial use and appropriateness in Canada, where we can do better in this space, and will introduce lessons learned from outside of Canada and a proposal for next steps. So without further ado, let me introduce Healthcare Can CEO Bill Fohl, who will be talking about AMS Canada and the Antimicrobial Stewardship Action Plan.
Thank you, Charles, and thank you all for joining us today. Merci à tous. Bienvenue à cette webinaire sur la gérance des antimicrobiens. We'll be conducting the webinar in English, but I invite any of you who wish to pose your questions off that stage to do so. It's my happy task to provide a bit of context and then turn it over to Andrew and Yoshiko. Healthcare Can, for those of you who might not be aware of who we are, we're the national voice of Canadian hospitals and healthcare organizations. You'll see in the next slide that we have some 53 members from across the country, literally from Island Health in Vancouver through to Eastern Regional Health Authority in Newfoundland and Labrador. One of the early, I've been in this job for about 3.5 years, but about 2 years ago we canvassed our board for what are the key things that keep you awake at night. And one of the things that the board identified was, the concerns around superbugs, C. difficile, and MRSA, and so forth. And so it was identified by my board as a priority. At or about the same time, the Public Health Agency of Canada came to us and said, listen, we need your help in terms of accelerating the work that's already underway toward what at that time was called a framework or a strategy. We suggested that Canadians were looking something further than a strategy or framework, but actually an action plan. And the action plan had 4 component parts to it, one of which is stewardship, which we're going to do a deep dive today. But just a reminder that there are some other elements to the work plan. We worked with the Public Health Agency of Canada and worked with them to identify what we saw as some of the leading practices in terms of antimicrobial stewardship. And thanks to our colleagues at CAHO, the Council of Academic Hospitals of Ontario, we were introduced to Andrew and Yoshiko and had an opportunity to have a site visit in June of 2015 where the then President and CEO of the Public Health Agency of Canada, Christine Othwaite, and the then Chief Public Health Officer of Canada, Dr. Greg Taylor, had an opportunity to see firsthand the wonderful work that's being done that you'll hear about a little bit later from Andrew and Yoshiko. Coming out of that, again, working very collaboratively with the agency and our friends NCID or NCCID from Winnipeg, the National Coordinating Center on Infectious Diseases. We were able to co-host a Change Champions roundtable in June of 2016. And coming out of that roundtable, and you'll see there, putting the pieces piece, by the way, was the missing piece was the antimicrobial stewardship piece. We had a good start on surveillance and public health promotion and research, but the missing piece was, in fact, the stewardship piece. So based on the deliberations coming out of that meeting in June of 2015, we identified 10 action steps. And I emphasize these, this was a facilitated session. These are 10 action steps identified by the Change Champions, for Change Champions, and each of the organizations that were in attendance there undertook to identify and make commitments in their own sphere of influence and control to help move the yardsticks forward. Now, we don't have time here today to go through each of the 10 in any kind of detail, but certainly one of the top action items was to form AMS Canada, Antimicrobial Stewardship Canada. That has now been done. And we're pleased to serve as the host secretariat, and Charles is kind of the team lead for the AMS Canada Secretariat. You'll see a couple of other nominate executive leads at the FPT process. One thing I wanted to stress here today is that what we're doing here today is being driven not just by an imperative by the federal government, but also an imperative of the federal, provincial, territorial public health community. It's being driven by the World Health Organization. The Director General there described antimicrobial stewardship or the march of the superbugs as a slow-moving disaster. It's been identified for the agenda of G8 and the upcoming meeting of G20. So this is actually a global imperative that we're facing. And while we're going to spend a lot of time talking today about the human health component, let's not forget that as part of an overall One Health approach, there's a whole other sort of parallel, synchronized effort being led by the Canadian Association of Veterinary Medicine. So that's dealing with the animal health. So here today we're going to deal with the human health part, and we're going to do a real deep dive, especially as relates to action step number 7. Just come back a second. Action step number 6, our colleagues at the Canadian Institutes for Health Research, who are on our steering committee, they received $2 million in the next to last federal budget earmarked for antimicrobial resistance, and they're working away and developing a research initiative that would focus particularly on diagnostics, so that we can determine what is and what is not a good candidate for the use of antibiotics, as well as looking at down the road incenting the development of new antibiotics as the current antibiotics kind of lose their effectiveness. We're going to focus particularly here with Andrew and Yoshiko's help on action item 7, and so I'll put that to the end. Developing guidelines and microbial prescribing. Suffice to say that we have dueling guidelines out there, and we're working with the prescribing community, the physicians, the dentists, community pharmacists, to try and address that issue. And then, of course, one of the things we want to do, with, again, the encouragement of government, is to look at knowledge mobilization and knowledge mobilization network. But that, again, is down the road. So at AMS Canada, we exist. We met face-to-face for the first time, I guess, on October 31st, Halloween. And we've had about 2 or 3
We're told that the sound is breaking up. Can you just help closer to the microphone?
Sound is breaking up, okay. I hope that's clearer for everyone. Please let us know if it's not. So AMS Canada exists. We've had one face-to-face meeting on October the 31st, and we've had several teleconferences since that time to try and move the agenda forward in terms of the action plan. And we've agreed to certain terms and conditions of engagement in terms of how we're going to work together by consensus. Again, the Public Health Agency of Canada has been very generous in terms of providing some initial seed funding to get us going. So thank you, NCCID and Public Health Agency of Canada. And our intent is to reconvene the change champions, keep them informed about what we're doing and engaged and seeking their assistance. So we intend to reconvene the change champions probably sometime in the fall of 2017. So the next slide, we have 16 we've added over the last little while to the steering group. It's co-chaired by Healthcare Canada and NCCID, and Margaret and her colleagues out in Winnipeg. Supported again, as I say, by the Public Health Agency of Canada. But you'll see there that it's going to take a full court press to actually fight the superbugs. And in the short run, next slide, please. We've identified three sort of fast-tracked, or what Charles calls table-setting activities. The first one is to develop an evaluation protocol, and so we've been tasked by the steering committee to work with a consultant to actually come up with an evaluation protocol that so that we can track how we're doing, so that you only have one chance to establish a baseline, and that's what we're going to do, establish a baseline against which we can evaluate whether we're making progress in terms of the appropriate use of antibiotics. Canada tends to have this penchant for reinventing the wheel. I call it Not Invented Here syndrome, NIH. So we've got some great public education programs like the Do Bugs Need Drugs program that's out west. Let's not reinvent it. Let's work with the community and try and educate Canadians so that they're not walking into physicians' offices demanding antibiotics when we know they don't work. And the third and last part, which is, I guess, a segue into what we're going to talk about mostly today, which is about the importance of developing consensus around when to prescribe what drug for what purpose. And again, Canada is not an island. It's a global effort, and you're going to hear from Andrew and Yoshiko about an experience from down under in Australia, and the team here in Ottawa, Andrew and Yoshiko will be joining us from Toronto. We'll be pleased to answer any questions that you might have at the end of this. So at this point, my time is up, I'm being told. So we'll turn the webinar over to Andrew. Andrew.
Okay. Thank you, Bill.
Or Yoshiko.
It's Yoshiko, yes. Dr. Andrew Morris and I are really pleased to have the opportunity to be speaking this afternoon. And as the title of our presentation suggests, and as you described so well in your introduction, we'll be addressing the current state and potential future state of antimicrobial surveying and surveillance in Canada. The objectives of this presentation this afternoon are to review antimicrobial use and appropriateness measurements in Canada. And while we've been able to report on antimicrobial use and antimicrobial resistance in Canada, there still remains gaps and limitations with our surveillance, of which we will address today. Then I will hand over the baton to Dr. Morris, who will review international efforts around use and surveillance, and will also provide a potential path forward for Canada and how we measure antimicrobial use. So many of you are probably familiar with the Canadian Antimicrobial Resistance Surveillance System report, known as the CARS report. And the first CARS report was released in 2015, with the second report being released a year later in 2016, with data up to and including 2014. The CARS report itself lends itself well to our current understanding of antimicrobial resistance and antimicrobial use in Canada. And this report contains surveillance data from 9 of the Public Health Agency of Canada's existing surveillance systems and laboratory reference services. With respect to antimicrobial use data sets in humans, the 9 PHAC surveillance systems can be categorized into 3 broad groups. And these groups are Information Management Solutions, IMS Health Canada, CNIS, the Canadian Nosocomial Infection Surveillance Program, and Health Canada data exploring First Nations and Inuit health. If we take a deeper dive into the IMS Health Datasets themselves, there exist 3 which we will discuss. And these are the pharmacy dispensation data, and in particular, the Canadian CompuScript dataset. And this tracks prescriptions and costs of antimicrobials dispensed by community retail pharmacies in all of the provinces, but not the territories. This subset of data also includes non-traditional prescribers, such as dentists, optometrists, nurse practitioners, and pharmacists in some of the provinces. Next is the hospital purchase data. The Canadian Drugstore and Hospital Purchases Audit actually tracks prescriptions and costs of antimicrobials purchased by approximately 650 hospitals across Canada, again excluding the territories. And finally, there's the physician diagnosis data, specifically the Canadian Disease and Therapeutic Index dataset, which involves a sentinel network of Canadian office-based physicians, including generalists, family physicians, and office-based physician specialists. Then we have the non-IMS data, which includes 2 other categories of data. CNIS conducted a pilot targeting specifically surveillance of antimicrobial use, whereby antimicrobial use data was obtained from 21 participating hospital pharmacies. Total defined daily doses of antimicrobials per site or per hospital were obtained for the years 2009 to 2013, and defined daily doses per 1,000 patient days were actually calculated from that. The goal of this pilot was to demonstrate feasibility of antimicrobial use data collection and to evaluate the potential link between hospital-based antimicrobial use and the emergence of antimicrobial resistance. The last data set, which is a non-IMS health data set, is Health Canada's non-insured health benefits, the NIHB program data set, for which non-insured prescriptions are captured. And the NIHB program provides insurance to cover prescriptions, including antimicrobial prescriptions, to Indigenous individuals. Like some of the other data sets mentioned, we don't have data for the territories in this particular data set. So talking about this data, these data sets wouldn't be complete without showing what this data actually looks like. So to illustrate some of the data seen in the CARS report, here's a graph of pharmacy prescriptions and hospital purchasing by year. According to the data, in Canada, antimicrobial use in humans has remained relatively stable over the last 8 years, with only slight changes observed in the total antimicrobials purchased by hospitals. Actually, we've seen a slight decrease of 4%, and no changes within the total antimicrobials dispensed by community pharmacies in 2014 compared to 2013. Here is a table, a next table, of the top 10 antimicrobials dispensed by community pharmacies for an 8-year period. We've seen a decrease in ciprofloxacin prescribing, which is a broad-spectrum antibiotic, and an increase in other agents such as cephalexin and amoxicillin, which are narrow-spectrum antibiotics. So this is a good trend that we're seeing. But still, on average, 65% of Canadians fill the prescription for antimicrobials for bacterial infections in 2014, resulting in a total of 23 million prescriptions dispensed. And here, this graph illustrates diagnosis and antimicrobial prescriptions per diagnosis. For many of the conditions, antimicrobials are not necessary. And what we're seeing here is that 40% of all antimicrobial recommendations were provided for treating respiratory infections, of which 38% were for treating upper respiratory tract infections, followed by acute bronchitis, and then also acute sinusitis. So although we have a number of surveillance sources from which to extract our data, that we've just demonstrated, we still have a number of gaps and limitations in our data set. In particular, the IMS data is not validated, and this is not unique to Canada. Other countries that use IMS data as their surveillance data source also do not have their IMS data validated. There also appears to be some overlap or misassignment between outpatient and hospital purchasing and questions of internal validity. The next slide is an example of what we're talking about here. So here's a table of the top 10 antimicrobials dispensed by community pharmacies in Canada in 2014 by province and territory. The data here illustrates that Alberta has a high defined daily dose per 1,000 patient days compared to Quebec. Here we have 6,233 versus 4,462. But if we look at this next table of the top 10 antimicrobials purchased by hospital in Canada in 2014 by the provinces, the data here illustrates that Quebec has a high defined daily dose per 1,000 patient days compared to Alberta, who has a lower defined daily dose per 1,000 patient days. And given what we saw in the previous table, it's not what we would have expected, and it sort of leaves us scratching our heads a little. So the point here is of internal validity. There may not be consistency across the provinces as to how each of the hospitals or outpatients assign or define what is hospital and what is outpatient prescribing. Sort of asking myself, how can one province be good at one but not in the other? And finally, an additional limitation is there is no attribution of burden of illness. For example, if there's an overall increase in number of patients, will we not expect an increase in prescribing as well? We have an aging population in Canada, and we might expect to see an increase in antimicrobial use, thinking of the healthy 35-year-old versus the 85-year-old. So is our antimicrobial use in Canada stable because there is no change? Or are we doing better because there is an increase in burden of illness, but rates have actually stayed the same? I'm not quite sure. And finally, we have no measurement of antimicrobial appropriateness in Canada. Antimicrobial use alone only tells us how much we're using, and it doesn't tell us if we're using antimicrobials appropriately, which is what we like to say the holy grail of antimicrobial stewardship. So at this juncture, I'm actually going to hand over the baton, so to speak, to my colleague, Dr. Andrew Morse, who will be reviewing the international efforts around antimicrobial measurement and surveillance.
Thank you, Yoshi. And once again, it is a pleasure to be presenting to you today. And I'm going to try and give you a slight overview of some of the other efforts that have been occurring around the world to try and capture antimicrobial use data. In the U.S., the most comprehensive attempt to track use comes through their NHSN network. This is a national network that has been in existence for many years now that has focused on primarily inpatient patient safety, although more recently it's expanded to go outside the inpatient care site. And one of the new innovations that they've introduced in the NHSN has been the antibiotic use option. And what this does is it standardizes how each hospital collects data on antimicrobial use, and then they enter that data into the database. So what we have essentially is an online database. It's centralized, and each hospital will then enter their own information. One of the things that they're trying to do in terms of gathering appropriateness data is using what's referred to as the SAR as a surrogate, and I'm going to go into that in a little bit more detail. So SAR refers to the Standardized Antibiotic Administration Ratio. And what that really means is in a particular hospital or at a particular site within a hospital or a particular service, they measure the days of therapy that is used at that location. So again, it could be hospital-wide or it could be specific to a particular service or location within the hospital. And then they compare it to peers. So for example, if your hospital uses on average 300 days of therapy per 1,000 patient days, and the average is 200 amongst your peer hospitals, then you're going to have a SAR of approximately 1.5. So what you're hoping to have is at least to be within range of your peers or have a SAR of around 1. And if you have a SAR considerably lower than 1, the assumption is that you're using less antimicrobials than your peers. And if your SAR is higher than 1, then it would suggest that perhaps your use is higher than your peers. And here's some graphics that I've captured from their databases. And you can see here that this is the information that they would be able to see right in front of them. And in this slide here, you can see in the green the antimicrobial days at each of the facilities. So on the far left-hand column, it shows which facility it is. It's facility 13860. We have quarterly summaries, which is what the next column shows. And then you have the antimicrobial days. And what is next to that is what should be expected compared to their peer hospitals for the same number of patient days that they have had in that hospital. And so they get calculated as SAR. It basically gets fed out to them, as well as some estimates of how different they are or the reliability of the estimate of the difference compared to their peers. So that p-value just suggests whether or not there's a confidence in terms of difference compared to their peers or not. If the p-value is low, it would make it more likely that any difference compared to their peers is statistically significant. And what I'm just showing here is that one of the advantages that they have with the system is that they can break it down, and hospitals can choose to enter data according to site as well. So their options tend to be intensive care units, medical wards, and surgical wards. The next thing, and I apologize, there's an error here on the title of the slide. This should be referring to ESPAUR. So ESPAUR is the English Surveillance Program for Antimicrobial Utilization and Resistance. And this has been in existence for just a few years. And the aims of ESPAUR have been to develop, maintain, and disseminate high-quality data around antimicrobial resistance, stewardship, and use. And perhaps one of the most laudable goals is to use this data, feed it back, and hope that this will lead to behavior change, quality improvement, process improvement, and eventually be reflected by antimicrobial resistance and patient safety. What they do is they use somewhat similar to what Yoshi was showing related to the CARS report. They have use of antibiotics that are prescribed in the community from this NHS, or the National Health System Business Services Authority database. And they then also have hospital antimicrobial use from a separate branch of IMS, which Yoshi also referred to, known as Quintiles IMS. That was previously IMS Health. And that captures almost all National Health Services hospitals in the UK. And it gives information on drugs dispensed both to individual patients as well as wards, and it really covers the entire United Kingdom. The one caveat, of course, which is different from what we have in Canada, is that they have a fair number of private hospitals and private care, and that's not included in this database. So this is all related to their public system. And similarly to what we've seen both with the SAR and with the information that we have in the CARS report, it doesn't address appropriateness. The majority of antibiotic consumption, as you can see from this graphic from the ESPAUR report, you can see in that top blue line, the majority of consumption is from general practice or primary care. The other thing that I want to highlight, and this will certainly give us insight as we move forward in Canada, is that dental prescribing is equivalent to about half of total hospital inpatient prescribing. And we have learned over time that antimicrobial use reservoir, being dentistry, is probably far more important to overall antimicrobial use than we've traditionally appreciated. Whether or not it's significant in terms of antimicrobial resistance is a different question that remains to be answered. The other thing that I want to highlight from the ESPAUR report and really highlight some of the efforts that have been undertaken in the United Kingdom refer to a pretty dramatic reduction in terms of cephalosporin use in community practice, as well as fluoroquinolone use. And some of you may have been aware of the recent data tying reduction in fluoroquinolone use primarily with a dramatic reduction in C. difficile infections in the UK. And this sort of validates some of the data sets that were shown in that paper as well. So I want to look elsewhere. I'm not sure if people recognize the map on the left. Hopefully you recognize the one on the right. But if I put it right side up, I think you'll recognize that we're looking towards Australia now from the upwards position. Many of us who have been involved in antimicrobial stewardship have been impressed with the efforts to get surveying and surveillance data in Australia. So in Australia, they have a National Center for Antimicrobial Stewardship, and in 2011, they launched their first survey known as the NAPS, or the National Antimicrobial Prescribing Survey. What the Aussies did is they developed an online survey and audit tool that required frontline healthcare providers to gather real-time patient-specific information and evaluate it according to appropriateness. This effort was endorsed by the Australian Commission on Safety and Quality in Healthcare, which is really their national quality and standards governmental agency in Australia. The small graphic below alludes to the fact that NAPS has expanded since it first started. So whereas it started with hospital NAPS, it has subsequently moved to include aged care, surgical care, quality improvement, and in fact, they're expanding to now also include primary care and non-human use as well. So they have taken a One Health approach to antimicrobial use and surveying, which is obviously something that us in Canada are interested and excited about because of their broad-based approach to antimicrobial use and stewardship. I'm going to focus a little bit on the hospital NAPS in particular. It's certainly the most developed and we have the most information around it. And some of the features that make what they have done so appealing include that the surveys are available 24/7 for having it used as a tool for their own reporting, so that if you are an individual hospital and you're interested in your own data, you can actually complete this survey any day of the year. and you can repeat that survey really at your own whim. The survey is designed to meet the needs for a variety of different settings. So as I alluded to a little bit, it not only includes regular inpatient care, but it has consideration for different patient populations. And in addition, the tool was developed to consider different hospital sizes as well and locations. So whereas I think, as Yoshi was alluding to, one of the challenges with the databases that feed into the CARS report, we are limited in the information we have from the territories, for example. The audit tool that they developed through NAPS allows for rural hospitals, both academic and community hospitals, and hospitals of various sizes to be able to provide information. Similarly, because some hospitals have significant challenges with human resources in terms of doing audits, hospitals can choose to perform audits based on certain wards, certain services, or they can obviously do it hospital-wide should they wish. Another thing that has made the NAPS very appealing and certainly has set them up for success is the degree of support that the Australians have embedded into rolling out the NAPS. So we recognize in Canada that most non-academic hospitals, unless they're fairly large community hospitals, don't have infectious disease expertise. And that could be infectious disease physicians, medical microbiologists, clinical microbiologists, or pharmacists with infectious disease expertise. And I also recognize that perhaps those involved in infection prevention and control might also contribute to efforts around this kind of auditing. But because many hospitals don't have this kind of expertise, the NAPS was designed and developed to have clinical support at the back end to support those clinicians who don't have the confidence in terms of assigning appropriateness. And that issue of appropriateness is what I want to talk a little bit more about right now. So I don't expect you to read the slide on the graphic on the right around appropriateness definitions. But what I do want to highlight is that they've broken down appropriateness into a variety of different categories. Certainly there are some patients who you can't really assess the appropriateness. You don't have from a chart audit the information that's necessary to adjudicate whether use is appropriate or not. Another thing that they have the advantage of in Australia is for a lot of antimicrobial use, they have national guidelines. In Australia, they have national guidelines for many clinical conditions, not only infectious disease or antimicrobial guidelines, but they have guidelines covering a wide variety of healthcare that is endorsed nationally and followed nationally and is published annually. We obviously don't have that in Canada. We certainly don't have national guidelines around infectious diseases and antimicrobial use. So one of the benchmarks that they do use is whether or not use is consistent with guidelines. But they've certainly embedded the opportunity to evaluate use even if guidelines in a certain circumstance are not available. And what they do is they decide whether appropriate antibiotics are optimal or perhaps at least adequate. So for example, it's possible that somebody has a pneumococcal infection that is susceptible to pretty well every antibiotic one would think of, and yet the patient's on a very broad spectrum, let's say a carbapenem, which that would be considered adequate, but it's not considered optimal. It's not something that we would necessarily endorse. Then they also have inappropriate use, and inappropriate use may be suboptimal or it may be inadequate, right? And The suboptimal could include the choice, the dosage. It could even relate to, for example, the route or duration, whereas inadequate basically means that we're not adequately treating the infection or there's undertreatment. What I'm showing you here are some screenshots from their database. And what you can see here is that the patient ID on the top of the graphic on the left, so it's a numerical ID, so there's no personal health information included in this whatsoever. It's totally anonymized. And we have the auditors, so the on-site auditors are able to put in the indication for the antimicrobial. There's a fair amount of detail, so you can see on the far right-hand side where it's been exploded, you can see that there's several options for example, in this situation, for the respiratory tract infection or what kind of pneumonia. It also allows for evaluation or compliance with guidelines if guidelines exist, but as I mentioned before, there may not be guidelines available. And then it requires the adjudication. This obviously requires some degree of training, but I'm fairly confident that the Aussies have been successful in validly and reliably adjudicating appropriateness and ensuring pretty high quality of auditing, primarily through support and training. And one of the things that they've been able to do because of this kind of data is that they've been able to sequentially or annually publish reports on antimicrobial prescribing practice. At the moment, it's been primarily focused on Australian hospitals because that's the greatest experience they have in terms of their databases. But certainly as the audit tools expand to the other settings, they'll be able to provide reports in different healthcare jurisdictions. And what you can see here on the left-hand side is in different colors, ranging from the lighter color, which is yellow, 2013, all the way to the maroon, or 2015. And you can see the amount of antibiotics in different settings that have been used. On the left-hand side on this slide, rather than the choice of antibiotics, you can see the most common indications for prescribed antimicrobials in public and private hospitals. And I think that's another strength of the system that they have, for example, over the ESPAUR hospitals in the UK, is because this is fairly voluntary or entirely voluntary, there's no boundaries in terms of data systems. There's no boundaries in terms of how the hospital is funded. It's all actually open in many ways. It's not really open source, but it's certainly open access. And so any hospital can contribute to it, or for that matter, any service or ward could certainly contribute to this. And over time, one of the benefits that they've had from this is they've had increased recruitment of hospitals because hospitals are able to get more information back, and I'll be going over that shortly. And as you can see here in Table 10 on the right-hand side, you get an understanding of where the inappropriate prescribing comes from, looking at all antimicrobial prescriptions. And certainly a large percentage of prescriptions don't have an indication. Many have too narrow antibiotic spectrum. Similarly, there's a lot of antibiotics that are too broad, and there's still many problems with duration, dose, and route. So there are significant gaps that they've been able to identify. But one of the advantages, of course, related to this is once you have a better understanding of appropriateness, you can target where you see the deficits are to guide quality improvement efforts. So they, as I was alluding to before, they have three kinds of report types available to users. There's a dashboard report, a detailed report, and a benchmarking report. And I'm going to be going over those sequentially. So the dashboard report, which you see here, and I have to admit I'm a pretty big fan of their fuel gauge that they have at the bottom, or speedometer. I think it's probably more looks like a fuel gauge. And you can see there that obviously they want to get to green, but it's a colorimetric indicator of how well they're doing. As you can see here, there's compliance with guidelines, documentation of indication, appropriateness of the antimicrobial or the prevalence of appropriateness, and whether or not the reviewer stop date is documented. And this just gives merely information for each hospital. So in this example, you're looking at Royal Melbourne Hospital, Parkville, and we can see that about 48% of patients, or as it's listed there, 47% of patients are on antimicrobial, so that's the prevalence of antimicrobial use. And you can see here that in general, they have about 80% of antimicrobial use is optimal, even though there's a fair amount that don't fall or are non-compliant with guidelines, but they have opportunities to explain. They do have the ability to provide fairly detailed reports by antimicrobial, by ward, by specialty, by how the prescription is assessed, and also they can have national aggregate comparisons. So as you see here, with this benchmarking, the hospital can compare their own data. So it says here, my data, that refers to the own hospital, and you can compare it to national data. So it's not exactly reported in the same way that the SAR, the antimicrobial ratio that is presented in the U.S., compare it with your own and the expected or anticipated antimicrobial use. But you can see this certainly visually, and you would even be able to somewhat compare or create a ratio. So as you can see here, the hospital example has more patients compliant with the overall compliance with guidelines is 62% compared to the national average of 52%. There's significantly less that is non-compliant, and directed therapy is even about 7% higher than peers. So anyone working in this hospital would at least feel somewhat reassured that compared to the 195 other hospitals in the database, that they're doing quite well. So just to summarize, and I think this gives us enough time for some questions, antimicrobial use and appropriateness measurement in Canada really has moved tremendously forward over the past number of years with the CARS report, but it remains still in its infancy. There are important gaps in Canadian antimicrobial surveillance, especially around appropriateness or adjudication of appropriateness. As I hope you've been able to see, other jurisdictions have made a variety of different attempts at measuring antimicrobial use. I've just tried to highlight a few specific jurisdictions, the U.S., the U.K., and Australia. Obviously, there are others, but these are pretty good exemplars. And I would say that Canada's best apparent option is to try and replicate in some way what the Aussies have done with the NAP survey. And I think with that, Yoshi and I will open it up for questions.
All right. Well, thank you very much, Andrew and Yoshiko, for that very informative presentation. We do have some time for some questions, and I see that there are a number of people typing theirs up. But we do have one question from Susan, which is, for NAP, who enters the data? For each hospital, for example, would it be one person who is assigned so that there is no duplication? What do you think?
So the methodology, this is Yoshi, the methodology that is used for entering data, there is a training module that anyone who is entering the data, so it would be one of the clinicians, it can be a pharmacist, it can be an infection control practitioner, what have you, a physician as well, pharmacist. And each of these individuals would require some training on how to use the tool, so it doesn't necessarily need to be the same individual at each of the sites.
Okay, so the next question is from someone who has signed up as guest. So how is NAP funded? Dr. Morris mentioned the Aussie system is voluntary. how does one get buy-in, and what has been the experience in terms of primary care?
So, I think one of the substantial benefits that hospitals get from participating in this kind of auditing activity is they actually get information on their own use. As I'm assuming our audience is primarily Canadian, as many people know, for hospitals in Canada, it's an Accreditation Canada requirement to have an antimicrobial stewardship program that includes some degree of data collection and reporting, and as well as actionable items. And that's what we have, that's what the Australians have been able to do with the NAPS, is even though there is some investment for the hospital actually gains quite a bit. They learn about their use. They have data that's been sort of manipulated for them so that no one's spending time doing all the calculations, messing around with spreadsheets. They get the data churned out to them in a nice format that's able to be presented to a variety of different stakeholders. And it also highlights opportunities for quality improvement. So, I think that for all those reasons, they haven't really had to convince too many people to participate. And certainly as time has gone on, as more people or more hospitals have been participating, what's happened is it's almost been an expectation for many hospitals that they should be participating or need to be participating so that the people who fund the hospitals, their peers, patients, and other advocacy groups can gain a better understanding of how antimicrobials are being used in each of the hospitals. And if you don't report it, it becomes, to some degree, almost like a red flag.
We have a question here from Jacqueline Arthur. Could Dr. Morris highlight the results of the NAPS on prescribing practices in Australia?
So I think they've had variable success at the moment. It's still early days. One of the things so on the aggregate, if you look at aggregate prescribing practices in Australia, it's somewhat difficult to know, but if you look at hospitals that have been participating and you look at the trend over time, it would appear that appropriateness and optimal use over the sequence of reports that have been provided by NAPS shows that there has been a gradual improvement. So it would appear, if we're trusting and going by this data, that at least for participating hospitals, we've seen a progression in terms of good use of antimicrobials. But I think it would also be fair to say that, because so much of antimicrobial use falls outside the hospital, this is only a very small part of, what I think the Aussies have as an overall long-term strategy around antimicrobial use. And we'll have to see over the next few years if they are equally as successful as they continue to roll out in what they term aged care, what we would call long-term care, and in primary care in particular, as well as dentistry, and then eventually the non-human use.
So we have a question here from Michael, and I'm hazarding a guess on the pronunciation, Gurgis, and I may extend it for my own purposes. For the Aussie system, what level of data is open to the public? Is it the site level? And my extension of that would be, for a prospective NAPS in Canada, how would that work given the way that our system works? Would it be at the regional health authority level, at the site level, at the department level? How do you imagine that working?
So my understanding for the Aussies is that the reports are what's publicly available, and if a hospital participates, they're able to see the national peers, and that's really all they're able to see. I think if we were to do this in Canada, that would be an important discussion to have in terms of the issue of transparency and hospitals not only hospitals being able to see their peers individually, I think for the public as well. So I think that's an important discussion. Personally, I'm a very strong believer in openness and transparency. Anyone who's ever gone to our own website at antimicrobialstewardship.com sees that we put all of the data basically that we have on antimicrobial use and the resistance associated with it and costs, et cetera. Those we publish quarterly, and we have them widely available. But what I think is best, or what Yoshi and I think is best for our program, I think is a entirely different conversation nationally. And the one thing you wouldn't want to do is turn many hospitals away for fear that they may be in some way penalized by trying to improve the quality of care.
So going back a couple of steps, I missed one of the earlier questions, and it seems to be a more general question, asking about the role of infection prevention and control professionals in antimicrobial stewardship programs generally. What would be the role of such a person in an ASP?
So I think there's a few ways to answer that question. It's an excellent question. You know, I tend to see the challenge around antimicrobial resistance and infectious diseases in a fairly holistic manner, so that the microbiology lab, the patients, prescribers, other healthcare professionals, infection prevention control, and the antimicrobial stewardship program, they all play pretty important roles in preventing people from getting sick, treating infectious diseases, and avoiding the development and spread of antimicrobial resistance. But I think it would also be fair to say that one needs to be certainly flexible around staffing of programs, but I don't think that we would want, for example, my antimicrobial stewardship program to be doing infection prevention and control in my hospitals. Would probably do a pretty lousy job. And I would think that the people, the members of my team, which include pharmacists, nurses, physicians, none of us are trained in infection prevention control, and so we wouldn't be appropriate primary members of the infection prevention control program. But I think we're really important collaborators with IPAC in our organizations, and you know, we interact with them very closely and strategize on a lot of problems that we have in common. I think it would be similar to say the same thing about infection prevention and control, where infection preventionists, you know, their role is to prevent the development and spread of infectious diseases. And, you know, expertise around antimicrobial use, for example, aren't really the jurisdiction of an infection preventionist, nor is it part of their training in a large way. Now, could someone acquire that? Absolutely. And I don't think that's in any way a barrier, because one can certainly develop expertise. And do I think that IPAC members or infection preventionists are really important parts of stewardship efforts? Absolutely. As I said, we collaborate really closely. But I wouldn't say that they're a necessary part of a stewardship program, just as I've alluded to already.
Okay, I think we just barely have time for one more question. It's a bit of a doozy, but I'm afraid I'm going to have to ask for a quick response, which is, how does one measure the magnitude and impact of antimicrobial resistance in a systematic way?
Well, I think that's a very complex question, and the answer is really complicated. I'm going to point people to two papers, one by Ramanan Laksamanarian, and I apologize for the long name, but it's Laksamanarian, and the other one is by Josie Hughes, where I was an author. And both of those papers have tried to develop methods of quantifying the importance and the size of antimicrobial resistance in a global manner by using principles that economists use. So economists, you can't really measure the size of economy. When we talk about inflation, what economists do is they look at key bucket indicators to measure inflation. And similarly, we need to be able to do similar things for common infectious diseases to do it. So things like, respiratory tract infections, urinary tract infections, et cetera. And that's what we've sort of proposed. That's what Lexman also in a similar manner proposed, probably with a little bit less detail, but perhaps easier to understand. So I think that's the simplest way that I can answer it, but this is a extremely complex question to answer.
Granted, and if you could actually send those citations to me, I'll make sure that they're distributed to everyone who was registered for this call.
Yeah, I can certainly send the references. I'll have to see, depending on each of those where they're published, whether they can be disseminated widely because of copyright reasons.
Right, of course. Okay, well, we'll see what we can do with that. But for anyone who has any remaining burning questions, I'm afraid we don't have time to answer them here. However, if you would send your questions to my email address, which is cthompson, that's with a P, cthompson@healthcarecan.ca, which is the same email address from which you received the reminders for this event. I will forward those and we'll see if we can get answers to you as soon as possible. If you have any comments or suggestions to inform our work in this space or additional questions, we'd love to hear from you. So once again, if you would send those my way. And then finally, we have a evaluation. I know that not everyone remains with us and not everyone has the time to fill those out right now. But if you would be able to fill out that evaluation, it helps enormously in our quality improvement efforts. It's not only hospitals who attempt to improve their quality. And the link to that is here and will also be sent to you in the coming days along with a recording of this webinar. So once again, I wanted to thank Bill Thole, Andrew Morrish, and Yoshiko Nakamachi for their presentation today. I know I at least learned a lot. Thank you very much.
Thank you.
This conference is no longer being recorded. You will now be disconnected by the moderator.